Will, are we good to go?
Okay, I think we're all set, Madam Chair.
Okay, very good. We are going to call this meeting to order. Will, could you call the roll?
Thank you. Senator Jason Rayford. Assemblyman Ken Cooley.
Here.
Senator Jack Pate. Representative Colleen Burton.
Here.
Representative Martin Carbaugh. Representative Peggy Mayfield.
Here.
Representative Joe Fisher.
Here.
Representative Deanna Frazier. Senator Paul Utke.
Here.
Representative George Kaiser. Assemblyman Kevin Cahill.
Here.
Senator Bob Hackett.
Here.
Representative Eddie Lucio. Delegate Steve Westfall. Here. Representative Rick Gundrum. Senator Monica Martinez. Delegate Kay Corey. Representative Joe Keller. Representative Bill Henderson. Representative Natalie Figueroa. Representative Robin Smith. Okay, and I do see, I see Senator Jack
Yeah,
Pate
that's problem
there.
solving stuff, I think, to do. That's cool. Like, totally fix that. We just gotta send it.
And I see,
This is a big deal, Patrick.
if you're not speaking, if everyone can
They
their
went to
phones,
another
please.
MMD, whatever call.
Somebody needs to mute their
And they said
Zoom,
that
please.
we're not gonna accept any more claims that you guys.
This is Representative. I didn't hear my name, sorry.
Yes, I just getting to you, Vice Chair Deborah Ferguson. I see you there. I also see Pennsylvania Representative Wendy Thomas.
Thank you.
And are there any other legislators present that I did not call? Okay, and we have obviously in Chair Hunter, so we'll just need a motion to waive the quorum requirement, Madam Chair.
I'd make a motion to waive the quorum requirement.
Second.
All in favor?
Aye. Aye.
Opposed?
Hi.
Abstentions? The motion carries. We've waived the requirement. Thanks, Will. Good afternoon, everyone, and good morning to those of you on the West Coast. Will, we have Martin Carbaugh here as well, too. I don't know if you got his
Yes,
name included.
I see him. Thank you.
I know everyone is very, very busy. It's a beautiful day here in sunny Syracuse, mid 80 degrees. I know everyone's really busy, and the realities of what we're facing relative to a global health crisis in which we find ourselves is obviously very stressful. So I really appreciate your participation today. As you can see from the agenda, this committee has a lot of work to do over the next several months. Accordingly, I had asked to call this interim meeting because I wanted to make sure that when we meet in September for our summer meeting, air quote summer, that we are not pressed for time, such that people feel that we aren't rushing through topics and that we properly vetted all of the things that we had wanted to go through. We're going to get started today with the final discussion on the NCOIL short-term limited duration insurance model sponsored by Indiana Representative Martin Carbaugh. As you know, this model was first introduced as last year's summer meeting, and the committee has had extensive discussions and has heard from those on both sides of the issue. Accordingly, today will be a final opportunity for legislators and interested persons to offer comments on this model before we take a vote at the committee's next meeting in September. Of course, between now and then, any feedback that you have about this model, please make sure you forward that along. After that, we're going to have a discussion about the NCOIL Healthcare Sharing Ministry Registration Model Act, also sponsored by Representative Carbaugh. This model was also introduced at last year's summer meeting, and at this point, opinions on the model have varied, and we're going to make a formal decision on how to proceed today. The committee will hear from Chris Myers, the Executive Vice President for Reimbursement and Strategic Initiatives from Air Methods Corporation regarding an air ambulance subscription membership products and the legislation or in the legislative and regulatory environment surrounding them. And we probably will not have another discussion at the summer meeting about a model, but we will have a discussion and a model at that time in December if we choose, obviously, to move forward. And lastly, we'll have an initial discussion on the possible development of an NCOIL telemedicine model act, which we'll discuss later. At this time, we're going to move to our first discussion point, which is the short-term limited duration insurance model act. Representative Carbaugh, the floor is yours.
Thank you, Madam Chair. And I have to tell you, I love your glasses.
Thank you.
So I just want to thank everybody that's helped me with this bill and worked on this model. The input's been great, and hopefully we're getting this to a spot where we can have a model to take back to our states where there's interest in the short-term duration plans. As I've said before, I believe strongly in the short-term insurance plans. They're products that can really help people, especially the uninsured. We've seen that in Indiana since we've expanded ours. This model is based on that Indiana law that was signed into law a year or so ago and has been on the market. And what we've seen too that should be noted is an expansion of companies coming into the market, providing more competition, which we see hopefully lowering prices in that as well. But it is important to note states are free to oversee and regulate and even ban these plans. I know some states have. That's why I included the drafting note in section 2 of the model stating, I'll just read, states are not required to offer short-term limited duration insurance plans. For states that choose to offer such plans, this model is intended to serve as a framework that can be adjusted accordingly to meet each state's needs. I think the drafting note's important because I know opinions differ on the value of these short-term insurance plans, and some states have in fact prohibited their sale. I of course disagree with that, but those with those states, and I'm a strong believer in the product, but nonetheless, it's important for the model to be clear that states are not required to offer these plans. The model is meant to be a framework to build on those states that do offer such plans. Before I begin on some changes that we'll be putting into this, it'll be distributed in the 30-day materials next week, so I want to go over those. Note that the changes are largely based on comment letter submitted by Blue Cross that was dated January 31st, 2020. Oh, pre-COVID, we love those times. And I want to thank them for taking time to prepare that letter because we did take a couple of things from it. The first part is a new section that will be titled Applicability, and it will read, this act shall apply to short-term insurance plans delivered or issued for delivery to residents of this state, regardless of the status of the contract or policy. However, nothing in this section shall invalidate a plan validly delivered in another state. So I think that language is important to include to recognize the fact that in situations such as when a short-term insurance plan or when the plans are delivered to a group or association in one state and then sold to consumers in another state, The insurance regulators have jurisdiction to regulate all short-term insurance plans covering residents in their state. However, the language I'm proposing makes clear that short-term plans are not nullified if they are delivered or sold in a state that permits the sale of the plans, but then they reside with the consumer in a state that prohibits such plans. So if, for instance, I were to buy one of these in Indiana, move to a state that's that prohibits them, I shouldn't have my plan devalued or invalidated just because I moved to a state that prohibits those plans. And I might not be able to renew it in that new state, but I shouldn't have it canceled on me. Number two is a section that will be added regarding rescissions. It'll incorporate the same rescission standards as applied to group and individual health insurance coverage, essentially an insurer that issues a short-term insurance plan cannot rescind such a plan once the enrollee is covered, except for an act or practice that constitutes fraud or intentional misrepresentations of material fact. It's consistent with the requirements of the Public Health Service Act, and I believe this is a very important consumer protection that we should include in the model. And lastly, a couple of things that are really more technical in nature. Sections 3C and 6 will be amended to replace the term participating provider organization with network-based plan. In the last draft of the model, we had changed the title of Section 6 from preferred provider requirements to network-based plan requirements. So it applies to network-based plans, including preferred provider organizations, health maintenance organizations, and exclusive provider organizations. Accordingly, using the term network-based plan throughout the model is appropriate for consistency, so we make those changes. And also in Section 6B3I, I'm sure you all know what that is. A couple of housekeeping amendments will be made to the citations to the federal code in the form of periods between CFR and the inclusion of the section symbol. So with that, I'm open to making further edits, but I do want to be ready to vote on this at the, as you said, Madam Chair, summer, air quotes, meeting in September. So with that, I'll turn it back to you and listen and answer questions.
If I don't know how we generally use this, but if there's any questions, that way people aren't over talking each other, if you could maybe raise your hand. I know every one of you has been in multiple Zooms for months at a time. So if you could just raise your hand, we could go through calling on people that way instead of people just shouting out. So entertaining any comments, questions, or concerns about this model for Representative Carbaugh. You could use the raise hand function if you have any question, comment, or concern. I'm not seeing any. Oh, we have someone, so we have the raise hand, function obviously on Zoom, but I did see someone manually raising their hand, sir. You could go ahead.
This is JP Waisky with the Health Benefit Institute. I do have a question related to the one of the new sections, the extraterritoriality section. Obviously, we haven't seen the language, but I think there's a concern that in a lot of cases, these policies are issued from an administrative standpoint from one state, and they're sold into other states. And it looks like it sounds like the language that you're talking about doesn't just allow consumers to take their plan with them, but limits the ability of consumers to be able to buy plan through associations that typically go this route. Is that your intent, or is that because that's typically something that my understanding is Blue Cross has pushed in other states, and so that would be a concern in the model from us from an extraterritoriality standpoint. Thank you.
Representative Carbaugh, would you like to make a comment?
And actually, can you restate? You're bouncing around on my screen. I don't know where to look.
No, I'm wearing the yellow shirt. I'm sorry.
Yeah, I know. So say that again. It's what was that term you used?
Yeah, in a lot of cases, short-term plans are sold on an association basis, which means that it's filed in one state through the association and then sold in a variety of other states. That allows for a lot of administrative simplicity for short-term plans. And the description of the language that you talked about, the new language that Blue Cross Blue Shield suggested, it sounds like there may be a limit on the ability of insurers to continue to sell those products in states without directly filing them in all 50 states. So it creates an administrative difficulty. And so that's a concern, potential concern, not having seen the specific language you're talking about in the final model.
I don't see that as what we're getting at, but once the final language is out, I'm happy to discuss that with you.
Wonderful, thank you.
Are there any other comments, questions, concerns? I don't see anyone having used the.
Madam Chair, I know there's Brian Blaze. I know he had a couple comments on this issue.
Okay,
Hey,
I
thank
see
you.
you, Brian. Go ahead.
Hey, thank you, Madam Chair. And thank you, Representative Carbaugh, for all your great work on this issue. And it is really encouraging to hear about the success, initial success in Indiana, and hope that continues. I spoke at the annual meeting in December. Just as a reminder, I was special assistant to the president at the White House National Economic Council from 2017 through 2019. And also, for your reference, I wrote a piece in Health Affairs last week on what I believe is a proper role of government regulation for the short-term market. Very briefly, we know exchange enrollment remains well below expectations. There's about 15 million fewer people enrolled in the exchange plans, as the coverage there is simply unaffordable for most people that don't receive large subsidies. Short-term plans are a crucial option for millions of Americans. One health economist, Chris Pope, conducted a study last year that compared ACA plans with short-term plans and found that for equivalent insurance protection, short-term plans are much lower, in some cases half the cost. And unlike in the ACA markets, people really do have an incentive to obtain high value from short-term plans because they are spending their own money. States should allow people to purchase what works best for them, and just for market innovation. And so plans can best meet people's needs. Policymakers should avoid imposing sweeping mandates on the plans. I believe, and I think the proposed amendments largely make sense, I believe many of the standards in the proposed legislation are reasonable, particularly as they pertain to more robust disclosure of benefits and limitations. I do believe there are two sections that merit further review. Section 6, which sets network requirements, and Section 8, which restricts how short-term plans can be priced, I believe will do more harm than good. In particular, Section 8 will reduce choice in plan innovation, increase the number of people without insurance, harm those with pre-existing conditions, and lead to more denials of coverage. In closing, I urge you to focus on arming consumers with information about these plans, but allowing maximum consumer choice and market innovation. Thanks for your time.
Martin, did you want to add or comment on that, or are you good?
No, I mean, I've talked a little bit with Brian about Section 8, which I'm looking at, and Section 6. Section 6, I don't think is too detrimental when you look at how the existing industry exists. They all have networks, and I can tell you in Indiana that was put in there as it requested from the healthcare folks that have called into question some of these plans. Now, I do think that these plans get conflated with other types of limited benefit health programs, indemnity type plans. That's not what we're talking about here. What we're talking about here is a substantial health insurance policy. Limitations, obviously we set a $2 million minimum benefit on this on an annual basis, which I think is appropriate, especially when you look at pricing. In Indiana, prior to the changes, a $250,000 max benefit plan and a $2 million max benefit plan had very small premium differences. And so I saw it fit to just say, let's not have that low benefit plan at the cost of healthcare these days. We need to have a robust benefit, especially if people keep them for 3 years. So anyway, the network I'm not as concerned about. Section 8, I'd be interested to hear what the committee's thoughts are on that. That, again, kind of came out of compromise discussions back in Indiana.
Okay. I don't see anybody having used their raise hand function. Are there any other legislators or interested parties that would like to make comment? If not, then we're going to be moving forward. We'll get this model draft in for the 30-day meeting materials that you will receive. And then we're going to go to our next agenda item, which is back to you, Representative Karbaugh, for the healthcare sharing ministry registration model.
Thank you, Madam Chair. We've had 3 very in-depth discussions on this issue over the past 3 meetings. Some may recall that I brought the issue to the committee primarily because of an experience with somebody I know, a friend of a friend who had a sharing ministry plan and ended up paying some bills that they didn't expect to have to pay. And so started to look into it, and I thought, NCOIL is a great place to at least open these discussions and start looking at this. And then I began to hear some similar stories. Obviously, we've got the one really bad actor we've heard about in Texas. But as you guys have been involved, or if you've been involved with some of these discussions at NCOIL, you know that the opinions on this are very, very different across the spectrum, from loving and hating this type of sharing of medical bills. And accordingly, NCOIL dictates more time and resources on this issue. I think we're kind of at a spot where those who really like it don't really want to see much in the way of regulation. I see others that are less excited about this industry, not wanting to, regulate and maybe validate. So I do think that we're kind of at an impasse. Definitely willing to talk with those interested in this. I do think that there's a place in the industry. It's a growing industry. I've had myself, being a licensed agent that help people with health insurance, I've had a lot of people reach out to me and talk about these programs, and I'm licensed with one of the providers and have presented it a lot. So I think there's a place. I think there are some common sense regulations, registration or licensing or something of that nature that could make sense. But anyway, I would entertain any ideas or thoughts from the committee. But I think at this point, we may need to table it and come back to it at a different time.
Okay. Anybody like to speak on this? I see someone having their hand raised. Thank you for using the raise hand function, Brad Neal. But are there any legislators? I just want to make sure we get to our legislators to have an opportunity to speak on this. I don't see any other hand raise function. So Mr. Neal, you're up.
Thank you, Madam Chair. This is Brad Neal. On behalf of the Alliance for Healthcare Sharing Ministries, we agree that the issue could use some more development and more discussion. We have no problem with tabling this. We still see a benefit to an organization like NCOIL promulgating a model for states to use. So we may ask you in the future to take this up, but we have no objection to setting it aside for now.
Okay, thank you. I believe Kevin McBride wanted to make a comment as well. Kevin, if you could unmute yourself, you're up.
Okay. Can you hear me now, Madam Chair?
Yes. Yes.
Awesome. Thank you. I'm legal counsel for Shareable LLC, a technology provider to the industry. We are working, a lot of people are working with IRS right now on a tax deduction for healthcare sharing ministries. That tax deduction issue should be worked through in the coming months it will include a definition, I believe, of a ministry. So our request is this: yes, let's table it for now, but not permanently, because there will be new developments, and we hope to re-raise those with the committee after IRS has finished its work.
Okay. Seeing no other raised hand functions, Representative Carbaugh, since this was your introduced model, you are advocating or recommending to table?
Yeah, I think so. I think that's where we're at, and the federal stuff being done, I think it's good for us to wait and kind of see what happens there. Also, by the way, I have had Zoom meetings, but I don't know how to use the raise hand function. I might not be the only one.
Okay, just a really quick for the future, because we have a couple more agenda items. If you go down to the bottom of your black screen and toggle, you'll see something pop up, and it'll say mute and stop video, and it'll show participants, chat, share screen. You see all those on the bottom. If you click on participants, it pops open on the right-hand side of your screen, and over there you will see little icons that say invite, mute me, and raise hand.
Got it.
Zoom 101. Okay, thank you, Representative. We're going to move forward. Right now, we're going to go into our discussion on the air ambulance subscription membership product. So if we could have Chris Myers unmute himself. And I don't know, Will, or does everyone have the materials sent to them, or is this going to be a shared screen for this presentation?
It will be both. They were, as you can see. All right.
Okay. Chris, you're up. And the presentation is on the screen for everyone to see.
Great. And it says Carolyn Miley, but it's Chris Myers. So thank you for the audience today. Thank you, Chairwoman. Really appreciate having some opportunity to speak with you today about this issue. And the objective for me is to really raise why this is an issue and ask that you look at regulating memberships. And so if we can go to the next slide, you know, just a little level set on what is emergency air medical services. This is an extremely rare service that happens about 350,000 times a year, or 0.01% of the population. The way that we work as a provider and other providers work is we do not self-dispatch. So we get a call when a medical professional or a first responder at the scene of an accident calls for our services. We have relationships or other with those folks, and when we get a call, we're off the ground 15 minutes. So
we're having a little bit trouble hearing you. I just want to make sure if you're close to your microphone. I know I was having a little trouble. I don't know if anybody else was getting a little distorted.
Okay, is that better?
Yes, thanks.
Okay, gotcha. Yes, I'll scoot in. So just back on kind of an outline of the industry. Again, we're off the ground in 15 minutes when we get a call. We don't know much about the patient at the time other than size and weight to make sure that they can fit in the aircraft. And, you know, we're essentially a flying ICU. So it's not just the speed to which we're moving a patient and the terrain, it's the services provided. We fly with a pilot, a nurse, and a medic, all of who have specialty care within trauma and within air medical to do things that most clinicians don't do, like intubating while in flight or providing drugs while in flight, et cetera. And then probably just the last thing to know is that, you know, we largely service rural America. So the typical type of scenario we run into is that a patient presents in a rural hospital with some type of condition, say maybe a stroke, and they're immediately transferred to a level 1 trauma center with the opportunity for that person to get a clot busting drug injected to them and walk out versus months and months rehabilitation. You know, in thinking about kind of the industry and what we at Air Methods did is, you know, we saw this history of some billing practices that weren't great, and we said, well, how can we change that? And so we essentially have adopted these 4 pillars that we've been working on the last 3.5, almost 4 years now, to both eliminate balance bills and get the patient out of the middle. And the best way to do that is to go get in-network agreements with payers. So we have done that over the last 3 years. We have gone from less than 10% in network commercial payers to over 50% today. The only real remaining payers we have to bring in network are United, Aetna, and Cigna. We've been working very hard to bring them in network, but despite those efforts, they have been unwilling to contract with us or any actually major independent national provider so far. But we'll keep working at that. We use a patient advocacy philosophy. So for those patients that are transported that have an out-of-network payer, as soon as we understand that, which is usually within about 10 days of transport, we reach out to those patients and assign them an individual and let them know from the beginning, hi, for example, this is Chris. We understand that you have Aetna as an insurance provider. Unfortunately, they're out of network with us. We're going to have a long process to get your claim paid, but we're going to work with you through that process, which will require, unfortunately, you, the patient, to be involved because your payer won't respond to us as an out-of-network provider. But if you can work through that process with us to file appeals, to provide information for them, we'll get your claim paid and you will have no balance bill. You will only be responsible for your copay. That's been very effective for us, and both in terms of reducing any out-of-pocket expense, reducing balance bills, and also just giving patients a sense of comfort in a time that is probably a sentinel event for them in their life. The next opportunity for us is to really fix the cost shift in the industry. So today, 70% of the patients that we fly reimburse at Medicare or less. So Medicare reimburses us about $5,800 per transport. Our average cost is around $12,000 per transport, and then that represents about 30% of our population that are just Medicare. Another 40% pay less than Medicare. So there's a massive cost shift in this industry, and it needs to be fixed. And we're working hard on work with CMS and HHS to allow ourselves to do cost reporting so that we can get a Medicare rate that was at least close to our cost. And then finally is what we're talking about today, which is air ambulance memberships and subscriptions. If we go to the next slide, the reality is that we've been able to have a lot of success in the efforts we've done without having membership. So as you see on this slide here, our average out-of-pocket for all patients, including self-pay, is only $167. So I was at the dentist this morning. I paid more than that this morning at my dentist office. So the strategies we've deployed have been very, very effective, and we're not going to stop until we can get rid of all balance bills. And that 70% is actually a typo. It's really 90% of our patients never receive a balance bill because of the in-network progress we've made on the commercial space. So, memberships were started with a good intention, and that intention was that, hey, payers are rejecting more and more claims, and we need to protect these patients from big out-of-pocket expenses. However, that landscape has changed, and as we have deployed the strategies I just shared with you, memberships become less and less relevant, and at this point have really become problematic. And why are they problematic? Well, they're problematic because patients really don't need them. As I mentioned to you, what a membership is supposed to do is to cover the balance billing portion that a patient may receive if their insurance doesn't pay. Well, as I described to you, the solution to that is get in network, so that's not an issue, which again, we're very hard to do. There's some areas that you can't force a payer to get in network, but it doesn't mean you don't stop trying. But for those that haven't, in our case, Aetna, United, and Cigna, again, we deploy the patient advocacy process so that patients still do not have to have a balance bill while they work through the process. And you don't have to pay for that, nor should you have to pay for it. The other issue with memberships is they're marketed and sold to people who don't need them. So if you look at the next slide, you'll see some of the marketing materials that go out here, which include things like a senior pricing. So why would someone with Medicare need a membership when they have a defined copay and deductible? It doesn't make any sense. And from our perspective, the folks that are selling memberships are using fear as a tactic to get them to buy a membership when, again, they don't really need it. And where membership started is kind of a backstop effort, they've now become a significant revenue stream for certain providers, where they have whole business models just around the membership program, and in our estimation can generate $100 to $200 million in revenue. Again, the problem with the memberships are, as you see here, they get marketed from a standpoint of fear and scaring you, so that the people that market them are actually kind of the arsonists and firefighters. So we have this issue. You unfortunately have to have an air medical transport, but if you don't buy a membership for us, boy, you're really going to be in bad straits when it comes to getting your claim paid. Well, it shouldn't be that way. And from our perspective, we do that for free. You shouldn't have to pay us a membership fee to do that. The other kind of thing to note is the way that some of these are sold is they'll fly a helicopter into a county fair and have everybody ooh and ah over how neat it is, but then say, hey, but if you have to use this, you could be stuck with a huge bill, so you need to buy a membership. So the gist of all of that is to say there are much more effective ways that don't involve consumers and don't involve patients in order to get claims paid. And that's the work with Payers to Be a Network, it's patient advocacy programs, and it's working in ways to not collect dollars from patients, but from the payer that they have paid their portion to reimburse the claim. So on the next slide, you'll see some of the specifics of why there are problems and potential solutions. I've touched on many of these things. One thing I'll highlight is you will see scenarios where patients will actually refuse a flight, will refuse transport, even though a doctor has ordered their transport because they have a membership and they don't know that the aircraft that's going to fly them is a part of that membership program. So it's created a dynamic where patients are not getting the care they need because they don't know if the membership that they have will cover the particular provider that they use. So just creating more confusion, which is also exacerbated by selling these to an elderly population that don't need them. So our ask is that we find a way to protect consumers from memberships. We believe they act and look and sound like an insurance product, and therefore should be regulated as an insurance product. And that's the ask of you and our hope to eradicate memberships so that the confusion and the fear that is used to sell them is eliminated. And with that, I'll be happy to take any questions you may have.
If you could remove the slide so I could see the screen.
Sure.
Thanks. Okay, if folks could use the raise hand function, that way we could start the discussion on this relative to the subscription membership products. I see someone with a hand raised with no name that says iPad 81. Can you state your name, please, and your organization? Oh, okay. It's iPad 81. How are you today?
Yeah, hi, it's Senator Hackett. I'm good. I'm sorry.
That's okay. Go ahead.
I just have a question for the gentleman. In Ohio, we're working very strongly of getting rid of surprise billing. We're very close. We just had issues getting any legislation done in Ohio, and so we'll get it done before the year end. And the providers, people on the call will tell you, the providers and the plans have agreed, and Department of Insurance did a great job at almost negotiating the final deal. So just the fact that there will not be allowed no surprise billing, is that a protection against, will Ohio even be a state that allows membership when there isn't going to be any surprise billing? This is just a question. What do you say about Ohio?
Yeah, I don't think that just banning surprise bills will get rid of memberships. I think memberships will still be sold because we've seen those marketed as a way to cover your copay and deductible as well. So even though you didn't get a surprise bill, you may have a high deductible plan and your membership can solve that. We believe that there's also some issues with that as well, because as most of you know, copays and deductibles exist as a means to prevent overutilization and are not supposed to be routinely forgiven. So that I believe that's problematic, and memberships will still continue even with surprise billing legislation. One other thing, you're welcome. Thanks, Senator Hackett, for the question. One other thing I forgot to mention that I think is important is that there is a committee that the Department of Transportation has started the Air Ambulance Patient Billing Advisory Committee that is tackling this issue as well, amongst others. I happen to be one of the representatives on that committee, and it's other industry representation as well. And so this is being worked on by that committee as well. There's nothing to report out yet. The committee started meeting in January this year with the goal to be complete by the end of June, and recommendations to Congress. With COVID coming, that did not occur, but we have resumed meetings through the end of October with a goal to get recommendations to Congress by the end of June.
Thank you, Senator Hackett. Are there any other comments, questions anyone would like to put out there? I'm looking at the raised hand function. I see my co-chair, Deborah Ferguson. You're up next.
Yes, I guess I'd just like to add that any legislation, I would hope that we would have measures in it to prevent it being sold to Medicare and Medicaid patients, and to maybe have some significant penalties for that, since those are covered services that the patient may not be aware of.
Can you make mention, I know when we spoke the other day, Chris, just a little bit about your conversations, I guess, and what you're trying to, I guess, facilitate with CMS relative to this?
Sure. So we have engaged CMS to look into these memberships because of this very issue. In our minds, we know of no other similar product or type of instrument that is sold and marketed to Medicare and Medicaid, for that matter, beneficiaries like this. So we have provided a memo to CMS that outlines the concerns with this. We've cited legal cases to support that, and we're going to continue to work with them as an opportunity to see how these could be regulated. To the co-chair's good point, which is that we need to start with protecting Medicare beneficiaries.
Thank you. I don't see any other raised hands relative to this. So as we work through, as I had made mention, we don't have anyone, a draft of anything of any sort right now, and won't be discussed at the summer meeting. So we'll be working through this through the fall, and hopefully when we convene in Florida in December, we'll have something more concrete to be able to talk about during that time. And for any member who's on, who's interested in forwarding comments, questions, or concerns, please feel free to forward that along. Thanks again, Chris, for your presentation.
Thank you, Chairman. I appreciate the time and appreciate the opportunity to speak to you.
Thank you. Okay, we're going to go into our discussion on the NCOIL Telemedicine Model Act. As we all know, COVID-19 has impacted several different kinds of industries and forced them to adapt, doing business in new ways. And one example of that adaptation is obviously the rapid expansion of telemedicine. It's not new. In fact, this committee discussed the issue at length several years ago, but the global pandemic has caused both federal and state telemedicine laws to be examined in order to make sure patients can receive the care they need without any delays, such as when quarantined during a global health emergency like the one in which we find ourselves. As an example of how significant the expansion of telemedicine has been, CMS reported there was an average of 13,000 telemedicine visits per week prior to the pandemic. But in the last week of April alone, almost 1.7 Medicare beneficiaries had a telemedicine visit. There appears to be almost unanimous agreement that once we finally return to a sense of normalcy following the pandemic, the expansion of telemedicine is here to stay. Some states have already taken action to enact legislation that would make many of the telemedicine flexibilities expanded during the pandemic permanent. I think this presents a great opportunity for NCOIL to get involved and provide guidance to states in the form of telemedicine model legislation, and I would be proud to sponsor such a model. Accordingly, I would like to hear from legislators and interested persons today as to what their thoughts are on what we should or should not be in an NCOIL Telemedicine Model Act. I would like to include a first draft of a model in the 30-day materials for the summer meeting, which will be distributed next week, as we've made mention. And this committee will have an opportunity to discuss the first draft in September. And, you know, just personally during this pandemic, I myself have used telemedicine you know, I found it to be very easy in a place like Syracuse where it's a transportation desert. For people who don't have, and especially in rural areas, opportunities to be able to get to appointments or get out, or concerned about transmission and COVID and having other kinds of autoimmune infirmities, so that they're worried about getting out. Telemedicine is really a great option to be able to use as far as a healthcare resource. So I'd like to open it up to any of the legislators or interested persons who would like to make comment about a telemedicine model, and we can just start that discussion now, please. Again, if you could use the raise hand function, it makes it easier to facilitate a conversation. And I have a couple of folks who've raised their hands so far, and I'd like to start with legislators first. And we're going to go to Representative Ferguson first, please.
Oh, thank you so much. Yes, I mean, I think if nothing else, this pandemic has really escalated the use of telemedicine. I mean, I passed the first telemedicine bill in Arkansas almost, I guess, 6 years ago. But I still think going forward, I mean, there have been certain exceptions for the pandemic. We still need it to be best practices and the best practice of medicine. You know, they waived copays and done some of those things during this COVID crisis. But I still think it's important. Our bill says that to establish a relationship, it has to be an audio-visual visit. Phone calls are a different thing. You know, Medicare pays for phone calls that are really a consulting fee. But if you're really having an audio-visual visit, I think parity and payment is important, because they're going to file the same CPT codes and get reimbursed on the same level if it's a 15-minute visit or a 30-minute visit. So parity is important. But also, my other concern is I don't want telemedicine to start going the way of the PBMs, where they gradually start impinging on the practice of medicine like they have pharmacy. You know, I don't want them to start requiring patients and doctor instead of being able to see their own doctor telemedicine because of the contractual arrangements. That's one thing. But also parity in payments. Those are and most people have already, you know, have telemedicine bills, but I think it's important to maintain those things. The other thing I see a lot of the telemedicine companies wanting is to call when a patient gets online and fills out a 25-page question. They're calling that a medical record, and they want that to be store and forward. Store and forward has been around a long time. My husband's a radiologist. They exchange medical information between doctors all the time, between their primary care and their specialist. Filling out a questionnaire online is not store and forward, because that is not sharing medical record information. So, I mean, those are the parameters that certainly I think are important. Some states have discussed the telemedicine licensing, and of course that's not an issue in Arkansas, because you know you can do telemedicine in Arkansas if you don't have a physical location. It's in maybe some other states can share. It's my understanding New York and Florida, some of these states, that it's more difficult to get a license in, that they don't allow you to do telemedicine in the state unless you have a physical brick and mortar location. That's not true in Arkansas, so I'm not sure, you know, about that aspect.
Thank you very much for that information. And I know Will, who is taking notes for us relative to this to make sure that we get some of this stuff included in the draft. Representative, we're going to go to Assembly Member Cahill next.
Thank you, Madam Chair. And thank you for convening this meeting. And hello to my colleagues and others who are attending. The concern that I've had all along with telemedicine is some of what was expressed by Deborah, and also what we've discussed in the past. We can't allow telemedicine to become a substitute for in-person healthcare when in-person healthcare is the appropriate means of delivering healthcare. I am concerned on both fronts, both in terms of insurers trying to over-incentivize or force consumers into telemedicine visits, And I am concerned about providers who would perhaps find a way to use those services in lieu of in-person visits when in-person visits are really what is more appropriate. Representative Ferguson mentioned the situation with Medicare. The situation with Medicaid does present a problem vis-a-vis telephonic or audiovisual meetings, in that many poor people do not have access to broadband. Many people do not have access to video services. And I know our federally qualified health plan in our community in the very beginning of the pandemic found it virtually impossible to conduct telemedicine visits. So what happened was people did without health care. The rule changed at the federal level, and they then allowed telephonic meetings that were not consults. They were actual full-blown office visits, but done over the telephone instead of with a video connection, because the consumer didn't have it. I think we need to have all these things in consideration when we're drafting a balanced model act, so that when it gets implemented in a state, it does not change the nature of healthcare. We also have to recognize, as was related to us when we were considering this matter several years ago, the vast difference from one state to another. Some places have a dearth of healthcare in their urban areas. Some places have no healthcare in their rural areas, and telemedicine is an important tool for that purpose. So this is not a piece of legislation that should specifically encourage or discourage the use of telemedicine, but it does have to take into consideration all of the competing and balancing interests. I would hope that our final model is primarily consumer-centric, and that protections are built in to accommodate some of the points that were raised. Thank you.
Thank you, Assembly Member. We have Senator Hackett next.
Yeah, I appreciate, and I appreciate my friend from New York. Years ago, 5-6 years ago, I worked hard to get the telehealth bill passed in Ohio, but one of the ways we were able to sell it was we didn't have premium parity. The reimbursement would be slightly less. But a lot of positive things have come out of this pandemic. And I mean, when you look at, I just was on a Zoom call where, you know, a medical hospital system has increased their telehealth by over 1,000%. I mean, they've gone from under 500 a month to 30,000 a month. So it's unbelievable, you know, how telehealth. Now, one point that I want to make is that where this is working so well is you're not seeing people run to the emergency room to the level they did in the past. You're also seeing appointments being held, you know, with providers. Providers will tell you that, and the assemblyman, my friend from New York, is right. It's the feds. That was a good move by allowing telephonic and not requiring it at all. And actually, you know, I've had, you know, like 4 telehealth interviews, and I just do them over the phone. It works really well. And so I think it's a good system. I really do. I mean, I understand, you know, we want people's health to be better. And I think people are actually seeing providers more through telehealth than they would in the past. But I want everybody to understand that, you know, the emergency room system is not, you know, one of our big problems in this country is people run to the emergency room not for the right reasons. And we've tried many times to try to change that. We're seeing a change. Now, I'm not sure when we get out of the pandemic if it won't go back to the old ways, but boy, it looks good. And so I'm kind of changing a little on the premium parity. You know, I know providers would make more money in a situation like this, but I think it's a win-win all along. I think costs will be better controlled. So, you know, this is something, you know, I don't disagree with my friend in New York. It's got to be done right, but we want people to be healthier. And I think people are now seeing physicians more. If you talk to the providers, they're seeing people more than they normally would see them. And they're not just seeing them because they're sick. And so I think the system might change in this country that could be positive. So thank you for letting me make these comments. And I think telehealth is a good thing. And we're working on legislation in Ohio right now. Thanks.
Great, thank you. As I said, we're going through the list of our legislators right now first before we get to others. So I see that your hand is raised, Brendan, and I will not forget you, but we're going to go to Representative Smith, Robin Smith, right now.
Thank you so much. And this is just speaking from experience in Tennessee. I know a couple of my colleagues are on the video. I would just simply say that to address payment parity and make this friendly for existing providers, we created a definition of provider-based telemedicine. And we contrasted that to what was existing in code of telehealth. Telehealth being facility to facility, and provider-based telemedicine being a Tennessee practitioner licensed and under the jurisdiction of our licensing and governing boards, whether it be a nurse, a PA, a physician, therapist, etc., that provider-based telemedicine would fall under that governance. And there would have to be an existing relationship with that Tennessee-based provider. This would in no way prohibit a contractual in-network pool of what I would consider kind of a franchise telemedicine, teledoc, MD Live. So this would be in addition to that, but this would be to permit Tennessee providers to interact with their Tennessee patients. And based on my colleague in Arkansas, Representative, I believe, Ferguson, you know, by using CPT codes that currently exist and by putting in code that all of this would be subject to utilization review, we were able to push the payment parity. And clearly we fought tooth and nail for 18 months with insurance companies, and it was the pandemic that prevailed and gave us this window of time to go operational. But I would be happy to work with anybody to use the Tennessee legislation as part of a model. It may have its imperfections, but I think that we were careful not to eliminate that which was already in existence, which has functioned as telehealth with facility to facility. We've just expanded it, and we've made sure that the cheaper franchise type telemedicine would not be impacted, and it would not creep into what we now call provider-based telemedicine, which does require a virtual visit, has to be live, does use store and forward, and that is that which is eligible for payment period. Thank you.
Thank you so much. We're going to go to next Representative Burton from Florida, and I see you, Deborah, and we'll get to you right after Representative Burton.
Thank you, Madam Chair and members of the committee. I just wanted to let everybody know that here in the state of Florida in 2019, actually the governor did sign we call it telehealth in Florida. It relates to the relationship of physician and patients or other medical practitioners as well. It's an open-ended, and that is a very broad piece of legislation. There is language in there though that I wanted to make sure everybody knew. Representative Ferguson mentioned out-of-state providers here in Florida. We do have a process whereby a physician licensed outside of the state of Florida can practice. It's delineated in the statute. We're really proud of this statute. We worked on it for a number of years. We have had conversations regarding billing, but at this point in time, we haven't moved forward on that particular issue. And I don't know that we necessarily will, because we haven't had the conversation in depth at this point. It took us a couple of years to get telehealth on the books. So we're very proud of it. We'd be happy to participate in a conversation in working on model legislation with you, Madam Chair, or anybody else who's interested.
Thank you. Representative Ferguson, we're going back to you.
Yeah, I just wanted to clarify, in Arkansas, if they're an existing patient or you have access to their medical record, then a phone call does count. But it's important that it be a medical record and not just an online document for you to treat the patient over the telephone. I mean, that's just our law.
Okay. Thanks. We're going to go to Senator Tate from Colorado next.
Hi, thank you, Madam Chair. I was able to carry the telemedicine bill and get that into law in June. one interesting question that came up at the end was to what degree should the availability of telemedicine physicians be able to be used to count towards network adequacy requirements? And I think it's a very interesting topic, as a lot of significant capital investments made in the brick and mortar, and this presents kind of a different model. I think that's certainly a topic that should be maybe talked about. That's all I had to say. Thank you.
Thank you, Senator. I don't see any other legislators with their hands raised. So Brendan, thank you for patiently waiting, and you are up next.
Thank you, and appreciate the time this morning, Chairwoman Hunter, Vice Chair Ferguson, members of the committee. Thank you for the opportunity to speak. During the pandemic, telehealth has emerged as a tool that improves access, which you've heard, by removing traditional barriers to the use of healthcare, such as distance, mobility, and time constraints, and for those individuals who are compromised, or for those doctors' offices that were closed, it allowed people to access healthcare. Let me state here that health insurance providers are supportive of the appropriate use of telehealth to provide access and reduce costs to necessary medical services to our members. Prior to the crisis this spring, telehealth was a growing industry, and most health insurance providers offered virtual access to their members, but uptake did remain low. As we've heard, trends have begun to change. Actions from the government and from health insurance providers has led to explosive growth. And Fair Health report showed an 8,000.
You're back.
I'm sorry. Okay.
Go ahead.
Okay. I was just saying, we had heard that the trends have changed, and that we've seen an explosive growth in the use of telehealth. There have been some key areas of increased flexibility during the crisis, including flexibility around originating sites, patient location, and provider location, increased allowance for the services available, providers eligible to practice via telehealth, and eligible technology. We've also seen permitting rural health clinics and FQHCs to deliver telehealth. In order to move forward following the pandemic, health insurance providers have some recommendations about things that can cement the positive changes we've seen regarding the use of telehealth. First, during the crisis, many states lifted restrictions on practicing across state lines. We've heard some discussion about this already. Physicians' ability to work across lines is determined by the state where licensure was granted, potentially restricting the ability of clinicians to deliver virtual care to patients outside the states where they're licensed. Our recommendation here is states should allow providers to practice in multiple states to increase access across the entire country, and allow for the creation of a national network of providers if that's something that makes sense. Next, inconsistent state regulations, restrictions, or mandates relating to the types of technologies, services, or specialties, or originating sites may limit health insurance providers' ability to design benefits that best meet consumers' needs. We have a number of recommendations around that. First, health insurance providers should retain flexibility in telehealth practices and be allowed to design benefits consistent with evidence-based care and in compliance with patient privacy rules. Also, we should expand the use of telehealth services to provide better access to care for people living in underserved areas. Telehealth can extend the reach of care teams, allow for round-the-clock monitoring, increase data collection to guide an individual's treatment, and may provide more timely responses to crises during treatment. And we should leverage telehealth to target services for underserved communities and ensure convenient access to high-quality, affordable care. A recent report from Teladoc indicated that half of behavioral health telehealth interactions were with men ages 20 to 35, a notoriously hard to reach demographic. As demonstrated by this example, some population groups may be more comfortable using telehealth as a means to receiving services. And we heard some of that again about the idea of encouraging people to seek care outside of the emergency room where appropriate. Finally, requiring equivalent telehealth and in-person payment rates eliminates the cost-saving potential of telehealth. And we've heard a lot of discussion around this, so I want to spend a minute. Our recommendation is to allow flexibility in negotiating appropriate payment rates for telehealth services. The savings from these negotiations can and do benefit the consumer. Payment parity may have made sense during the pandemic. Doctors' offices were closed. Patients couldn't get to their doctor's offices when they were open. Many patients are not comfortable, or for good reason because of compromised immune systems, should not be going to their doctors. But post-pandemic, we do believe that payment parity doesn't make sense, and it should be left to a negotiation. Telehealth visits do not always require the same level of intensity, the same amount of time, or the same equipment, most importantly, as bricks and mortar visits, and so should not require reimbursement parity. We also believe, as some have discussed, that telehealth should not become a replacement for needed in-person visits. One of the things we've seen that we are concerned about is a drop in necessary vaccination rates. Those cannot be done via telehealth, obviously, and we want to encourage people to go to their doctors. We don't want to create an inappropriate incentive to substitute a telehealth visit for a necessary in-person visit. So let me conclude with this. The explosion of telehealth under COVID has provided opportunities and raised new questions. Ultimately, the growth is good. Health insurance providers have been promoting telehealth use for a decade. We believe that much of what we have seen regarding the increase in utilization is positive. Telehealth has proven useful, especially among underserved and difficult to reach populations and geographies. Telehealth is not inherently higher risk than in-person services, but with increased volume, we need to make sure it is safe, effective, and efficient care. Thank you for the opportunity to speak, and we stand ready to work with you on any model development.
Thank you, Brendan. We have JP Weisky next.
Thank you again, and thank you for teaching me how to use the raise hand feature earlier.
You're welcome.
So I wanted to be just briefly a couple of things. So I represent the Health Benefit Institute as well as Horizon Government Affairs. In my prior gig, I was the Deputy Commissioner for the state of Wisconsin, worked directly on network adequacy issues. So I think that's a really important topic to understand in any model. I think for consumers in a number of cases, especially in a deeply rural setting, having access to telehealth can provide access to providers like dermatologists and others that are just not practicing in rural settings. So I think that's an important one to understand. The NEIC network adequacy model does include a section describing how telehealth can be used inside a network adequacy model. I would also note that I think we need to be careful as we go through this process that there's a lot that we can get wrong around telehealth. We've seen the movement of the regulations that have increased the availability, not just from COVID, but I think the availability of telehealth broadly has certainly increased, as been indicated. And I think that indicates the importance of regulatory flexibility around some of these pieces. I think looking at sites of service, I think licensing is an issue. There's been a lot of relaxation of licensing of medical providers. I think in a number of cases, it's not just the licensing for telehealth, it's broader licensing issues, including moving beyond just the compact licensing of medical doctors in this area. I would also note it's important to look at software issues and to do your best to not pick winners and losers. That, as has been stated before, in some cases, audio is the only way that individuals can access care. There shouldn't be issues surrounding that. In other cases, you should not be picking winners and losers between Microsoft, Google, and other products. And that's something that we've seen, I think, a number of states start taking a look at and has created problems. So with that, happy to help as we move down this process. Thank you for your time.
Thank you, JP. It looks like we have next Emily Carroll.
Great, thank you, Madam Chair. This is Emily Carroll from the American Medical Association, and I just want to state that we would welcome the opportunity to engage with NCOIL on a model telemedicine bill. In our view, a model is extremely timely as the COVID-19 pandemic is pushing stakeholders to really realize the value of care provided via telemedicine. For example, telemedicine is allowing patients, especially those vulnerable to COVID-19 complications, to continue accessing care safely and continuously with their physicians. It's also helping many physicians maintain their practice operations and retain their staff during stay-at-home orders and when providing in-person care is not safe or feasible. And it's proving to be an important tool in addressing long-standing health inequities, although we would say much work remains here to ensure that patients have access to broadband and other technologies. If the committee decides to move forward with the telemedicine model bill, the AMA would love the opportunity to offer a number of recommendations related to access, coverage, payment, and we'll probably plan to just offer those in writing as that may be more efficient. But I will say that our recommendations will focus on advancing telemedicine not as a replacement for in-person care, but as a valuable supplement to in-person care to improve coordination of care, to ensure that vulnerable populations have access to their physicians, and to realize the efficiencies and ROI that come with expanding the means by which care can be provided. So we are absolutely ready to work with the committee to advance telemedicine policies that promote patient access to quality care and capitalize on the important investments and advancements that have been made by physicians and other providers during this pandemic. So we look forward to the opportunity to working with you.
Thank you, Emily. I saw Representative Burton's hand raised. Did you want to make another comment, Colleen?
Yeah.
Or
yeah,
okay.
Thank you, Madam Chair. Just wanted to follow up, and I'm losing track of who's saying what because I don't have everybody's names written down.
That's okay.
But a comment was made. There's been several comments made related to payment parity, and I just want to make sure that when I made my comments related to payment, is that in Florida we haven't considered mandating any particular formulas for payment. Ours is here again, as it is in our practice code, our practice statute. It's also very flexible and open in the insurance statute, so that it leaves that arrangement, if you will, those decisions between both the providers of insurance and the providers of medical care. So that's where we're at that right now. And that, quite frankly, is one of, I think, now granted, it does allow for a certain amount of oversight. It requires a lot of oversight on behalf of our regulators. And sometimes that can be a challenge for both sides of the proviso, if you will, who's providing services, whether it be the coverage or the medical provider. But again, in re-examining what we've got, and it just speaks again to what I was saying earlier about in Florida, both when it comes to providing telehealth services as well as for the payment thereof through insurance products, it's pretty flexible and open, but it requires both the insurance companies, medical providers, and the legislature to constantly be in communication regarding what happens when the regulators come into place and perhaps make it more difficult for the continuation of those services. You can tell me I'm excited about this. We're excited about telehealth in Florida, and it's expanding like it is everywhere else. We're just happy that ours was so flexible from the get-go, so that when the pandemic hit, people could take advantage of the breadth of services. We have a lot of rural space here in Florida. We're not always known for that, but we absolutely do. We're not just beaches and sunshine, although we're a lot of that. But I want to make sure, just to kind of throw that out there as well, when it comes to payment, we see we see the parity that's happening right now in the pandemic. We see lots of things, no co-pays, lots of changes and things that companies are doing to adapt to make access more widely available. We don't necessarily expect to see the market wanting to sustain all of that once the pandemic ends in that hopeful day sometime within the next year. So thank you very much.
Perfect. Thank you so much. I don't see any other hands raised relative to this topic, but I thank everyone for their comments, and I definitely will have discussions and look forward to working with everyone going forward. Again, if you have any comments or like to send, I believe some people had read some written testimony. If you could make sure that you send that in, that we can get that in, and then consider everyone's comments and questions and concerns as we're working through to have a draft ready for everyone. Is there any other business that needs to come before this committee today? Hearing nothing, no one's hands raised, I am asking for a motion to adjourn.
So
Move
moved.
we adjourn, Madam Chair.
Second?
Second.
Very good. Motion to adjourn, all in favor?
Aye.
Aye.
Noes, abstentions, the ayes have it. You all have a wonderful, sunshiny, safe weekend, and will see you all in DC in September.
Good, thank you.
Bye, everyone.
Madam Chair.
Aye.
Welcome. Bye.
Aye.